Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Multiple Myeloma, facilitated by Dr. Asad Bashey with Northside Hospital Cancer Institute Blood and Marrow Transplant Program and the Blood and Marrow Transplant Group of Georgia. Please visit our website, cscatlanta.org, to see a complete list of live and recorded events. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to complete a new attendee form to stay connected to all future programs.
All right, so welcome everyone to Frankly Speaking About Multiple Myeloma. I'm Emily Brown, the Program Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community program, we invite you to visit our website, cscatlanta.org, to see all of our free oncology support services offered virtually, ranging from virtual support programs to monthly oncology nutrition seminars. If you miss a live event, you can always find a recording on our website. I want to highlight our weekly cancer support group that meets every Thursday for anybody who is diagnosed with any type of cancer, as well as our virtual family and friends support group, which meets monthly for any caregiver of someone with cancer. Both groups are led by licensed mental health professionals, and for additional information, you can go on our website, again, cscatlanta.org. All right, as I said earlier, everyone's going to be muted throughout the program. We invite you to answer questions in the chat box, which we will address at the end. And I want to welcome today's presenter, Dr. Asad Bashey. Dr. Bashey is board certified in subspecialties of medical oncology and hematology. He is the clinical research medical director for the blood and marrow transplant program at Northside Hospital and is also a Northside Hospital leukemia program physician. Dr. Bashey has been recognized as among Atlanta's top doctors in his specialty in Castle Connolly from 2013 to 2020. And with that, I'll go ahead and pass it off to you, Dr. Bashey.
Well, thank you. Hopefully you can all hear me and there's no echo. Well, thank you all for joining, and thank you to the Cancer Support Community for organizing this. This is to remind us that this program is developed and arranged by the Cancer Support Community. Some of the slides were developed by them. I've added to them in some instances. They have final control over the content of the programs. The program was supported by Sanofi, Genzyme, and GSK. I was engaged by the Cancer Support Community to present this program. Importantly, I have no financial relationships with either the Cancer Support Community or the sponsor of the program, Sanofi and GSK. So this program will be focused on patients and patients' relatives. If you happen to be a healthcare provider specializing in myeloma, then this is probably not going to be pitched for you. But we'll get a chance to ask questions and address any issues that arise beyond the slides here at the end of the program. So we're going to focus on some basic questions about what is myeloma, what are the symptoms it causes, what are the problems it causes, how do you diagnose it, how do you stage it, how do you monitor it, what are the treatment options available, the sort of things that you need to know about your disease when you talk to your healthcare provider, how do you select a healthcare provider, that kind of stuff. And as I said, there's going to be questions and answers at the end. So let's start off with the simple question of what is myeloma. Now, myeloma falls into the category of blood cancers, but just to remind everyone and clarify, in most cases, the myeloma cells or the cancer cells of myeloma are not circulating in the blood. They tend to sit mostly in the bone marrow. But generally, blood and marrow cancers go together. So myeloma falls under the general umbrella of blood and marrow cancers. It is a cancer arising in the plasma cells of the bone marrow. So that brings the question, what are plasma cells? Plasma cells are a normal component of the bone marrow. They're part of the body's immune system. Their job is to make antibody, and I'm sure you've heard a lot about antibodies from the recent COVID epidemic. We look at how people develop antibodies. Antibodies protect you against COVID. And it's these plasma cells that make antibodies against infections. As I said, the plasma cells are normally a small component of the bone marrow, typically less than 5%. And like any tissue in the body, it can become cancerous. And myeloma arises when one plasma cell acquires genetic changes within its machinery that allows it to expand and grow out of the normal checks and balances of the body. So myeloma is not the most common cancer in the world, but it is one of the more common cancers. About 1 in 132 patients, people are diagnosed every year with myeloma. It is typically seen more commonly in certain populations. Certainly, the older we get, the more likely we are to develop myeloma. For some reason, it is more common in African Americans than in Caucasians, and I think somewhat less common amongst Asians. If you are related to somebody with myeloma, your risk goes up, not substantially, but goes up. If you're a man, you have a higher likelihood of getting it. If you are overweight, your risk goes up. And certainly if you have a condition, an abnormality of the plasma cells that is not a full-blown myeloma, but is another abnormality that is related, then your likelihood of developing myeloma goes up significantly. So what is, like any cancer, myeloma is caused by changes in the genetic machinery of the cells. So there have to be several changes that are acquired by the cancer cell that allow it to grow outside the normal controls of the body. And then the question becomes, what causes these changes? How do they arise? And in many cases, these are random changes. As our cells divide, they have to replicate their genetic machinery. And in so doing, there can be random errors that arise that can lead to cancer. So for many cancers, there's no clear cause. However, some exposures, such as certain chemicals in the environment, can sometimes accelerate these changes and can predispose to the problem. So myeloma arises when the plasma cells, or at least one plasma cell in the bone marrow, acquires such changes. It then forms a clone or a population of cells consisting of that original plasma cell and all its progeny that then start to grow. And because they're growing more rapidly than they should, eventually they form a much larger component of the bone marrow than normal plasma cells do. When that happens, several problems can arise. And generally, the sort of problems that myeloma cells can cause fall into this acronym CRAB. And you know, myeloma, when it develops, can lead to high blood calcium, can lead to damage to the kidneys, can lead to anemia, and importantly, can lead to thinning out of the bone, leading eventually to bone fractures and pain, which can be very debilitating. But those are not the only problems, but they're the main issue that myeloma can result in. So what are these CRAB symptoms? Well, A in there stands for anemia. It is very common in myeloma that as these myeloma cells grow, they inhibit the production of normal red blood cells. And often patients can present or show up with a low hemoglobin that then leads to further assessments, and the myeloma is diagnosed. Myeloma cells tend to produce large amounts of one type of antibody, and in some cases that antibody can precipitate inside the kidney, cause other forms of kidney damage, leading to kidney dysfunction. And again, some cases of myeloma present when somebody notices the kidneys are not working right, and a nephrologist then investigates and finds that myeloma is underlying that problem. Bone problems are very common in myeloma because myeloma cells tend to grow in a patchy form throughout the bone marrow, and in some areas they tend to attract other cells that start chewing away at the normal skeletal structure of the bone. That eventually leads to thinning out of the bone, often in a patchy or moth-eaten form, so-called lytic lesions. And when they occur in areas that are important for weight bearing, such as the spine, that can lead to collapse of those bones that in turn causes pain and disability. And then, of course, if the bone is being chewed up, the calcium from the bone can be released from the bone into the blood, leading to blood calcium that is much higher than normal, which can then interfere with all kinds of bodily functions and cause lots of symptoms, such as, for example, loss of appetite, weight loss, but it can also affect the heart and other organs. Now, in the modern era, a significant proportion of myeloma patients are diagnosed without any symptoms. That's because we will go for routine blood checks, somebody finds an abnormal protein level and investigates further. So there are myeloma patients that are diagnosed before they develop symptoms, and that's probably better than diagnosing it later on. So when somebody presents with myeloma, what are the assessments that are performed? Of course, the physician will examine the patient, get a full history, perform some general blood tests like the CBC and the chemistry, but also perform specific blood tests that are relevant to myeloma, such as protein tests, such as certain tests that determine prognosis in myeloma. And these are all important to perform at the beginning, because without doing all the tests, sometimes you don't have the information you need to plan treatment. So what kind of tests are we talking about? In addition to routine blood tests such as the CBC and chemistry, there are specific blood tests that look at the abnormal protein that myeloma makes. And importantly amongst these are a test called SPEP, or serum electrophoresis, another one called SIFE, or immunofixation, and there's a third one called free light chains. Now, if you are a myeloma protein, you should really become familiar with these tests because they are important. It's important that your physician looks at these, and the results of these can help determine whether your disease is responding to treatment. So even though it sounds a little technical, it's important to get somewhat familiar with these blood tests. Now, as myeloma proteins can also be secreted in the urine, there's different ways to look at that, but at least initially, collecting your urine over 24 hours and quantitating how much protein is coming out in the urine is very important. Bone tests are very important. Originally, they were simple X-rays, but increasingly people recognize that doing CT scans, MRIs, or something called a PET scan may be more sensitive at detecting bony abnormalities that are caused by myeloma. All patients with myeloma require a bone marrow biopsy. That involves putting a small needle into the marrow space, taking some fluid and taking a little core of the marrow. That's very important for diagnosing the myeloma and establishing certain other things about it, such as its prognosis, because some tests, like what you see below here, the cytogenetics and the FISH test, can only really be performed on the bone marrow. So if you don't do the bone marrow, these tests really cannot be done. There are some specific blood tests, specific something called the B2M and the LDH, which are not routinely done if you go for a general physical examination. But once you're diagnosed with myeloma, it is important to do those tests because they help determine the stage of the myeloma. And if they're not done, then sometimes you cannot stage the myeloma. So this just sort of, is a slide that shows some of these labs, talks about what they are and what they're used for. Again, when we talk about the CBC, and chemistry, these are routine blood tests, often done in routine physical examinations. But then I talked about these specialized tests, the B2M and the LDH, which are used to stage the myeloma. And then some of these protein tests we talked about that help establish what type of myeloma you have, and also very important for following the myeloma to assess response, because measuring the abnormal protein produced by myeloma cells is really one of the best ways of assessing how the myeloma is doing. And of course, looking at the urine as well as the blood is important, and we've discussed that. So how do you diagnose myeloma? Well, it's important to distinguish myeloma from related conditions or disorders of the plasma cells that are not full-blown myeloma. Most important amongst these is a condition called MGUS, or monoclonal gammopathy of undetermined significance. You don't have to remember the full name, but this is a condition that is not a full-blown myeloma. It is an abnormality of the plasma cells, and it can in some cases be a precancerous condition that may increase the risk of myeloma. How do you distinguish it from myeloma? Importantly, on the bone marrow, the plasma cells are less than 10%, versus in myeloma, they're typically more than 10%. In MGUS, patients do not have any of those CRAB symptoms we talked about, such as anemia or kidney failure caused by the disease. And typically the level of the abnormal protein in the blood tends to be relatively low. But in this condition, there's about a 1% chance of developing myeloma every year, if you look at the whole population. But there are going to be lots of people with this condition that never eventually go on to develop myeloma. So it's important to distinguish, and certainly does not require therapy. There is a condition that is a type of myeloma, but is not as yet causing symptoms. That's called smoldering or asymptomatic myeloma, where the disease has gone beyond this MGUS stage For example, there's more than 10% plasma cells in the bone marrow, the protein levels may be high, but importantly, there are no other signs or symptoms of organ damage caused by the myeloma. And traditionally, this has been managed by watching and surveilling rather than treating, but there are some trials that seem to suggest that some patients may benefit from treatment. Well, what we know as myeloma is what we call full-blown or symptomatic myeloma. That's what we understand is real myeloma. And that's where, importantly, the percentage of plasma cells in the bone marrow is more than 10%. There is at least one of these crab things that we talked about before, such as anemia or high blood calcium or renal failure or bone problems. But it was recognized more recently that you do not need to have these crab symptoms. There are other features that indicate a very high likelihood of developing those crab symptoms soon, and so may in fact allow you to make a diagnosis of full-blown myeloma without having the crab symptoms. Importantly, you may have full-blown myeloma and not feel sick, so you don't have to have symptoms when you develop it. As I say, if you have one of these other features, we'll talk about them in a second. There is a condition called plasmacytoma, which is where the same process as in myeloma occurs, but is very localized to one area. For example, you can have a lump in soft tissues or a lump in one part of the bone and nowhere else. You look for myeloma everywhere else, you don't see it. That's called plasmacytoma. And it is causing symptoms often at that location and can be treated often in that located way by radiation or other forms of treatment. And it's a relatively uncommon situation, but it's something to be aware of. So again, just to summarize, this MGUS condition, typically the protein levels tend to be low, less than 3. There's less than 10% plasma cells in the bone marrow. None of those symptoms we talked about the myeloma can cause. And you can have this, it certainly increases your risk of developing myeloma, but many people will never develop myeloma. We talk about smoldering myeloma, which is beyond that, but still no symptoms and no damage from the myeloma, much higher risk of progressing to full-blown myeloma, about 10% risk every year. And then we talked about the full-blown myeloma, which has those crab criteria, has more than 10% plasma cells, but these are those additional categories where even if you don't have the crab symptoms, you can be called full-blown myeloma. If you have more than 60% plasma cells in your bone marrow, if the ratio of one of your myeloma proteins is much higher than the other myeloma protein, a so-called 100-to-1 ratio, that can make the diagnosis. Or if on an MRI you have at least one abnormality in the bone, that can sometimes indicate that you're about to develop these crab symptoms, and so you can take it as being essentially equivalent and start treatment. So talking about myeloma, it's important to understand that cancer is a genetic disease, not just genetic disease in the way that you pass it on to your kids, but a disease arising in the genetic machinery of the cell, in this case, the plasma cell. And so it's very important to look at that. One way we look at that traditionally is by growing those cancer cells outside the body, and then spreading out their genetic material into what's called chromosomes and looking to see abnormalities there. That's somewhat harder to do in myeloma because myeloma cells don't grow very well outside the body. So chromosomes and their abnormalities can typically be only seen in about 20% of cases of myeloma. Instead, the most useful test is something called the FISH test, standing for fluorescence in situ hybridization, that essentially looks at the same process, looks at the chromosomes, but now paints each chromosome with a different dye and looks to see if there are chromosomes that are joined to each other or they have had little bits of them snipped off. It's a much more sensitive test that can detect abnormalities in the vast majority of cases of myeloma and is therefore very useful, both in diagnosing myeloma, but more importantly in determining prognosis. There is a newer technology called next generation sequencing that is still not really in prime time for most myeloma patients. There are some formats that are developed. In the future, it may be used more, looking at a more detailed look at different genes and how they are affected in myeloma. That may eventually become an important prognostic tool, but is not being widely used at this point. So like any cancer, we typically stage the disease. By staging, for example, in breast cancer, stage can make the difference between cure and no cure. If your breast cancer is localized to the breast, it can often be treated. That's early stage disease and locally, and it can be cured. whereas often if it's spread to organs such as the liver, etc., it's often considered incurable. Myeloma is typically always disseminated when it's diagnosed, except if it is that very rare case of the plasmacytoma. So there's another way that we stage myeloma, not by looking at where it is in the body, but by looking at certain blood tests and the genetic tests I was just talking about. So typically the new staging system that is commonly used in myeloma is called the revised ISS staging system, for International Staging System. And basically it relies on a couple of blood tests. I talked about those before, something called the beta-2M or B2M, another blood test called the LDH, and on the chromosomes or the FISH testing of the bone marrow. So if you have a beta-2M that is greater than 5.5, then you are heading towards having the most advanced stage, stage 3, but you, in addition to that, need to have either a high LDH or abnormal chromosomes that are what's called high-risk abnormal chromosomes. If you have the earliest stage of myeloma, your beta-2M has to be less than 3.5. You have to have a normal LDH, and you have to have no high-risk chromosome abnormalities. And if you don't fit into either this category or this category, then you're in the middle, you're in stage 2. And basically, prognosis, outcomes, etc., are somewhat related to stage. Stage is not the only thing that matters, but is an important factor to determine how to treat the myeloma and how aggressive to be with it. So that brings us to the question of treatment. How do we treat myeloma? Well, traditionally, we've thought of myeloma as a disease that is very, very hard, or if not impossible, to cure right off the bat. There are other cancers which we can just cure by giving some treatment. It goes away forever, never ever comes back. Myeloma typically is not thought of in that way. However, myeloma is highly treatable. So we think of it as being not curable, but highly treatable, meaning that we can, by various tools that are at our disposal, make the myeloma shrink substantially, make its symptoms and problems go away, but it is not likely that we will eradicate the very last myeloma cell, so that if you live long enough, eventually the myeloma is likely to come back. However, the more tools we have, the more we can keep pushing it away and turn it into a chronic disease rather than a fatal disease. That's at least been the objective. Now, in the future, we hope to eventually get to a cure. But at this point, I think if somebody tells you, I'm curing your myeloma, you have to be a little skeptical that that's really happening. Okay, so how do you decide whether the patient needs treatment and what treatments they need? Well, again, a lot of the tests we just mentioned are really the ones that determine how you treat the disease and whether you treat the disease. But there are other factors. For example, particularly your age, whether you have a lot of health problems that are pre-existing and unrelated to the myeloma. And importantly, what are your goals and preferences? Are you somebody that wants to be as aggressive as possible? Are you somebody that says, no, I really would rather not have the most aggressive therapy. I'd rather preserve some quality of life, even at the expense of long-term survival. So the patient's wishes are important. And then the risk features, the stage and other risk features of the myeloma are important in determining how to treat the disease. So this just summarizes that, patient preference is central. It's at the end of the day, you are in the driving seat. Physicians can only advise. And so it's important to be in charge of what you prefer. But there are several things we take into account: age, other conditions. Is the myeloma causing symptoms? What is your geography? Are you somebody who lives, hours away from the nearest oncologist's office? Are you right next to the oncologist's office? What is the risk profile of your myeloma? If you treat it less aggressively, is it likely to rapidly progress? What are insurance issues? Sometimes insurance will refuse a particular treatment that we want to give, and then you may not be able to get it. And then, of course, your lifestyle and your goals of therapy are important in making that determination. So the same treatment is not necessarily appropriate for every patient. So how do you treat myeloma? I told you, if you have this related condition called MGUS, typically you do not treat that condition. It does not require active therapy. You're likely to cause more damage than help the patient by treating it. Instead, you should be monitoring the patient. And there are guidelines as to how frequently you should monitor it to see whether it is showing a tendency to convert towards developing full-blown myeloma. There are some data that some dietary supplements, such as curcumin, can sometimes maybe help. These are not strong, recommendations about changing your diet. If you have smoldering myeloma, which is the condition we talked about before, where you've crossed the boundary to have some features that we consider as being diagnostic of myeloma, but you do not have symptoms from myeloma, generally, you in the past, you certainly monitored this disease and not treated it because you're not going to cure it, and the patient is having no symptoms. How are you helping the patient's quality of life by treating the patient? But there are some data that if you have higher risk varieties of this smoldering myeloma, that you may benefit in some cases from treatment even before you develop symptoms. And that remains an area of debate amongst myeloma doctors. If you have active or full-blown myeloma, most people will agree that you need immediate treatment. And you typically cannot wait in that situation, because if you wait, it's very likely that severe symptoms will develop in the near future, even if you don't have them as yet. Many people have those symptoms already. And typically, the way you treat active myeloma, again, it depends a lot upon the patient, but you typically give some type of treatment to shrink the disease down substantially, so-called induction therapy. If you are relatively fit, you typically go on to consolidation therapy with something called stem cell transplant. And then typically you go on to long-term low-intensity therapy, so-called maintenance therapy. And hopefully you keep the disease in remission for as long as possible. If and when the disease eventually relapses, you then have additional treatment options available, and those options are continuously increasing. At the same time, if you have bony disease, you typically use treatments that either strengthen bone or prevent further bony changes from occurring. So we talked about MGUS. Again, active surveillance is the way to treat the disease. Healthy diet, of course, is recommended whether or not you have myeloma. And then, it's important not to get too obsessed with the fact that you have MGUS if you have this condition, because many such patients will never develop myeloma. It's important not to be paralyzed by the diagnosis, and important to get on with life and let the physician monitor the situation. If you have symptomatic or active myeloma, then really, I told you we need to start therapy. And generally, the way we treat myeloma is using drug therapy. Surgery, radiation have very limited roles in myeloma. Because myeloma tends to be disseminated from the very beginning. You typically can't just cut it out from one area and eradicate it like you can breast cancer. So drugs are very important. And in the, when treatment first started for myeloma, chemotherapy was all that we had. But since about the mid-90s, we've had these so-called biological agents, which work in a different way from chemotherapy, interfering with the biological machinery of the myeloma cells. And these are very effective treatments. They can have side effects just like chemotherapy can, and you have to be aware of those side effects. But generally, most people start off with these biological agents. Steroids are a normal body hormone. Your adrenal gland produces these kind of steroids, but we use them in much larger than normal doses as a drug, and they can directly affect the myeloma, kill myeloma cells, and they're really part and parcel of the treatment of all types of myeloma. So, we talked about stem cell, and we'll talk about that in a little bit more later. It's a form of consolidation. Generally, it is your own stem cells that are used with chemotherapy to consolidate, meaning improve the response you've already had to previous therapy. Donor transplants tend to have a very limited use in myeloma compared to other types of blood cancer. Radiation surgery, I told you, is limited use, typically for localized disease and for disease that is causing immediate and urgent problems. For example, if the myeloma is causing compression of the spinal cord by a local deposit there, then surgery and radiation can be the best way to decrease that risk of paralysis and other complications. But generally, you tend to avoid these treatments because they can have side effects and they don't eradicate the disease. Bone strengtheners are very important if you have bony involvement with myeloma, to both strengthen existing bone and to prevent new lesions from arising. And then, of course, if you already have complications from myeloma, such as anemia or a high blood calcium, then those can be treated immediately with treatments that don't directly treat the myeloma, but affect things like anemia, for example, transfusions or compounds that can decrease the blood calcium. And then, of course, some people still have pain even after their myeloma is treated, and complementary therapies are very important in order to avoid chronic use of opiates, which can be problematic in myeloma patients. So, and I don't want to get too into the weeds with this. Many of you are familiar with these drug categories, but I just wanted, this slide just generally illustrates some of these biological agents and chemotherapy that we have available for myeloma. One important category is the so-called IMID category. Usually the drug ends with IMID as its endpoint. These are the generic names. These are the brand names. These are typically drugs that are given orally, very active against myeloma. And there's typically three of them. The most commonly used ones are Revlimid or lenalidomide, and Pomalyst or pomalidomide. Thalidomide is used much less now because of its side effects. Another very important category is so-called proteasome inhibitor or PI. The most commonly used drug in this category is Velcade. These drugs are typically given intravenously or more commonly into the skin. There is an oral version called Ninlaro, which can be convenient in some cases. It's not clear it's as good as these other agents, but these are the two commonly used agents, Velcade and Kyprolis. Again, they're part and parcel of most patients' initial myeloma therapy. Chemotherapy, there's two commonly used agents, particularly a drug called Melphalan, which is used as part of the stem cell transplant, but also a drug called Cytoxan that can often be used up front in some cases. They still have an active role in treating myeloma. And corticosteroids or steroids are very important. Almost every patient with myeloma gets them. Decadron or dexamethasone is the more commonly used version, but sometimes people also use prednisone. Increasingly, we have developed new tools, including monoclonal antibodies. These are protein molecules. They're antibodies that specifically target certain elements on the surface of myeloma cells. The two most commonly used categories currently is a drug called Darzalex or daratumumab, and a less commonly used compound called isatuximab or Sarclisa. They both hone in on something called CD38 and have now become very important, particularly in the treatment of relapsed myeloma, but also in some cases for upfront therapy. Let's move on to, again, this slide really just shows the normal, if you have active myeloma, this is the sequence of treatments you go into. Induction therapy is the initial treatment you get to decrease the amount of myeloma you have substantially and head off symptoms or relieve symptoms that you already have. Consolidation typically consists of stem cell transplant, and that's a way of further decreasing the amount of myeloma in your body beyond what has been achieved by the induction regimen, and in so doing, delay the recurrence of the myeloma and give you a longer period without active therapy. Maintenance treatment is typically given after the consolidation phase and typically is low intensity, is usually oral, but in some cases can be given into the skin every couple of weeks, and it's continued long-term, often until the disease comes back. And then if and when the disease comes back, there are salvage therapies, of which there are more and more available that make our results of myeloma therapy improve with each year. So these are just some of the combinations, and I don't want to get stuck into the weeds with this. We don't have time to discuss each individual regimen. If we have questions, we can talk about them later. But again, there are many combinations up front that can be used. Typically, at least 3 drugs are used, some cases 4 drugs are used. There's a debate about who should get 4, who should get 3 in the myeloma community. Most people will get stem cell transplant. They're fit. Typically, if you're not fit, very elderly, have a lot of medical problems or lack of social support, you may not get this treatment. And then maintenance therapy typically is with an oral agent, but can in some cases be with Velcade, which is not oral. And then once the disease recurs, there are lots of agents available that we can use to treat the disease. This slide just talks about the stem cell transplant concept, which is used as consolidation. Again, that means we improve the response that has already been achieved with the previous therapy. It is really applicable to essentially all patients with myeloma up to the age of 80 if they don't have a lot of medical conditions, are not very frail. It has been shown to be successful in prolonging the duration of the remission in many large randomized clinical trials. It does use chemotherapy as the primary element to kill myeloma cells beyond what the biological agents have already achieved. The stem cell component really is just where we collect something called bone marrow stem cells. They're stored away whilst you get the chemotherapy, and then they're put back in your body after the chemotherapy is finished. And the job of the stem cells is to allow you to rapidly recover from the chemotherapy. They don't have any direct effect in fighting the myeloma. It is therefore not a true transplant. The word transplant is used commonly to describe this, but really this is not a transplant. Transplant by definition means you take something from one person, put it into another. That is not what you're doing here. You're taking your own stem cells out temporarily and then putting them back in your body. It is very safe. Generally, as I say, it can be applicable to most patients. So once the disease, the idea behind treating myeloma is that you make it go away for as long as possible, so that the patient can live a relatively normal life free of treatments, or at least on very minimal maintenance therapies, and just get on with life. But eventually we do expect the myeloma to come back. And I've seen it take 20 years to come back in some cases, but it eventually will come back if you live long enough. And then the question is, how do you treat it then? And it depends a lot about what you got up front, how that upfront treatment worked, how long the remission was, what side effects you had on that therapy, whether you have clinical trials available, etc. So there's a lot of complicated factors that go into deciding how to treat the disease when and if it occurs. But again, the mainstay remains drug treatments. Often we use different treatments from the one you got up front, but there can also be the usual supportive care treatments that we use up front, such as preventing bone complications, and other treatments designed to alleviate symptoms and complementary therapies. So again, this slide is a little complicated. I don't want you to dwell on this, but this just gives you examples of options that are available. For example, if you were on Revlimid maintenance after your initial therapy, and now your disease came back, well, typically you don't want to be back on Revlimid again because your disease has grown on the Revlimid. So typically most of these options here do not include Revlimid. On the other hand, if you are on Velcade maintenance, which is the maintenance given into the skin for some types of myeloma, then typically you don't want to go back on the Velcade. Although here there's one example where it is being used, but typically use other alternatives. And then if your disease was not on any kind of maintenance therapy and you relapse, then there are other options that include both Revlimid and Velcade. So importantly, once the disease recurs, it's important to consider clinical trials because that's how we make progress in developing new therapies, and it allows you to access some cutting edge treatments that you may not have access to otherwise. So once the disease comes back a second time, of course, some of the options that you had up front start going away, and then we can use some newer options, such as this drug Sarclisa. There's another drug called selinexor, which we didn't talk about, which is a newer agent that is used in people that have multiple relapses. There's also an agent called panobinostat, which works in a completely different kind of way. Importantly, clinical trials become more and more important the more the relapses that you have happen. And when you have very aggressive disease at the time of, sometimes when the disease comes back 2, 3, 4 times, it can start to get more aggressive, behave much more like an aggressive cancer than the original myeloma, in which case sometimes you do need a really aggressive chemotherapy combinations, which we often don't use upfront in myeloma. But there's also a newer agent that has recently been approved called Blenrep, which is really a combination of a monoclonal antibody and chemotherapy. It's very effective. It has to be given in specialized centers because you have to monitor for side effects on the eye. So there's a limited number of centers, including ours, that can give it. Not everybody can give it, but it's a very important new addition to the armamentarium. A limited number of patients do receive a donor transplant. Its role in myeloma remains unclear at this point. And of course, there's newer treatment options through clinical trials, particularly CAR T-cell therapy. So what is CAR T-cell therapy? This is something you may or may not have heard of. It's increasingly a new modality of treating cancer, it's approved particularly in lymph cancers and in certain types of leukemia, but will soon hopefully be approved in the treatment of myeloma. It's very different from other therapies because it is a type of cell therapy where you take your own body's immune cells, you ship them off. Those immune cells are then genetically modified by using gene therapy to redirect them towards attacking your own myeloma. Normally, your own body's immune cells are kind of, they are blind to the myeloma. They don't see the myelomas form. They don't attack the myeloma. This treatment basically redirects them to attack the myeloma. They consider a living drug because those cells are then expanded, shipped back, they get infused into your body, and they can expand in your body and sometimes persist for very long periods of time. They're generally autologous, meaning taken from your own immune cells. But increasingly, we are looking to develop so-called off-the-shelf CAR T cells, where somebody else's immune system cells are modified and are just taken off the shelf and given to you. That avoids you having to collect your own cells. So this is technology that's developing. There's some very interesting results. that I think are very promising, and we expect this to be approved very soon. So without getting too technical, this is how this is what we put into the CAR T cells. This is so-called the chimeric receptor. Basically, this is an antibody combined to another protein. This recognizes something on the surface of the myeloma cells. This bit activates the immune system cell, and this allows you to basically redirect the immune system cell to attacking myeloma. The surface protein that we target in myeloma is called BCMA, or B-cell maturation antigen. The reason why this is so useful is that this protein is really only present on the surface of the myeloma cells and some immediate precursors. It is not present on some of the earlier immune system cells of the body. So you can relatively specifically target the myeloma cells without affecting other cells in the body. And that's why this has become the popular target for the CAR T cell therapy. How do you do the CAR T cell process? You typically collect cells from the patient. Again, you separate out the immune system cells using a certain technology. You put in a gene into these cells. You then expand these cells outside the body, and then you ship them back and reinfuse them into the patient. So this process takes a few weeks. Sometimes you need treatment while you're waiting for the shipment to come back. And these are the two agents that are most ahead in terms of the approval process. One from a company called BMS and Bluebird, and the other one from a company called Janssen. We're hoping that these will be approved soon. The results have been very impressive. It's not clear that they cure the myeloma, but they provide a very important option. This is just showing you one bar curve. I don't want to get too technical again here, but this is using the Ide-Cel agent and showing that in very advanced myeloma cases that have relapsed many times, more than 4 out of 5 patients will have an impressive response to this treatment. So really, for these very advanced cases that in the past might have died from their disease or will be very sick from their disease, this provides a new option that could be very exciting in the future. Side effects of CAR T cells are somewhat peculiar. The two main areas that we have to watch out for, something called CRS, which causes fevers and other organ dysfunction. And there's a slightly later effect that affects the nervous system, neurotoxicity or ICANS. Both are very manageable, both are very treatable, and both typically are temporary, but they can be fatal if they're not recognized and treated appropriately. So again, CAR T cell therapy currently is performed in specialized centers such as ours. It is not performed in every office or every oncologist in town or in the country. This just shows you those two agents, Ide-Cel and Cilta-cel, the two agents that likely will be approved in the future. We don't want to get into the weeds of the details of these. I just want to mention one other type of treatment, which may have some of the benefits of CAR T cell therapy while being less complex. And that is a novel type of antibody treatment where, once again, this BCMA on the surface of the myeloma is targeted, but instead of using a cell to target it, you use an antibody that links that to the body's own immune system cells. So now, instead of taking the immune system cells out of the body and growing them and shipping them back, you just give an antibody that brings your own immune system cells into close proximity with the myeloma cell, thereby redirecting them to attack the myeloma. We've done a clinical trial with this, and we're very impressed with the results. And this could be a simpler way that avoids the complexity of CAR T cell therapy. So this is another exciting area that we expect to see developed in the near future. So this, again, brings us to the whole issue of clinical trials. Clinical trials are very important because that's how we develop new therapies. And that's how you can access some of these cutting-edge therapies at our center and others, which you cannot get, off the shelf as yet. So it's very important that we, participate in clinical trials whenever they are available. I also want to mention a little bit about bone pain in myeloma. This can be a really difficult issue and can be intractable. There's different ways in which you can get bone pain in myeloma. Firstly, when the disease is diagnosed or when it first relapses, you can have direct pressure from the myeloma cells on the bone that can cause pain. And typically that kind of bone pain resolves quickly when you treat the myeloma with either drugs, radiation therapy, surgery, whatever the appropriate process is. But there's also a more chronic pain that arises because the bone can sometimes be structurally altered by the myeloma. For example, the vertebral bodies can collapse, pressing upon nerves. And that kind of pain typically does not go away when you treat the myeloma because there's continued pressure on the nerve because you have a collapsed bit of bone. In that case, you may need some very specialized treatment, for example, injection of cement into the vertebral body to lift it up sometimes helps. And sometimes it may need chronic pain medication, but then there are other complementary therapies that can minimize the use of chronic pain medication, which can be problematic. And again, drugs that strengthen bone, including bisphosphonate and monoclonal antibody drugs, as well as calcium and vitamin D supplements, can help heal previously damaged bone. Important to consider non-drug options to control bony pain. So lastly, when talking about your healthcare team, how do you select and work with your healthcare team? Again, it's good to have an oncologist who's experienced in treating myeloma, but it's also important to have somebody that's local. It's no point you traveling, 4 or 5 hours, maybe, across the country to get your treatment that you might be able to receive locally. So you have to balance these things out. It's important to be able to talk openly with your physician. And it's very important that each patient's goals are independently assessed and appropriately managed versus treating every patient the same. You can always get a second opinion. It's important not to get too many of those though, but second opinions are important that help you see things clearly, see if all physicians are saying the same thing. And before you receive treatment for myeloma, it's important to know that what your diagnosis is, what your stage is. It's important to understand some of those protein tests so you understand how to follow them. Important to know who your care team is and how to get in touch with them. Very important to discuss side effects before you start a treatment so you can anticipate and prevent them from getting too bad before they're diagnosed and dealt with. And of course, if you have prior therapy and you have relapsed disease, it's important that your physician and you understand what those prior therapies were, you're aware of this, so that any side effects you've had previously are not recurred. And also, again, clinical trials are important, and second opinions may help you make that decision. Okay, these are the kind of questions you have to ask your physician. Why am I starting the treatment? Which treatment am I starting? What side effects will I get from this treatment? How are we going to monitor the myeloma? How will we know we're responding? Are there any costs involved? Some of these oral drugs, unfortunately, can involve high copays, and you need to be aware of that before a physician decides that that's the treatment option for you. And if and when should you switch from one treatment to another? Again, the clinical trial questions always worth considering. Are there any clinical trials I should consider? Is it appropriate for me to be on a clinical trial right now? For some people, taking a break from treatment is important. Myeloma, remember, we're not curing the disease with these treatments, so it's not crucial that you have to receive treatment exactly on time. Sometimes there's an important life issue. You can take a little bit of a break, although not too long. Again, what kind of family support do I need? What else can I do to stay as healthy as possible? And what other resources do I have? We talked about the second opinions. Again, it's something that's routine, but it's important to get some, but not too many, because sometimes people can be paralyzed by getting too many opinions and focusing on the minor differences between one physician and another. You don't want to get into that category. Okay, I'm going to stop here and take any questions as appropriate. Thank you.
Thank you so much, Dr. Bashey. That was a wonderful presentation. We have gotten a few questions. I did want to reiterate to everyone, if you joined us late or you just want to be able to look back as a reference on this video, it is going to be posted on our website, csdatlanta.org. You'll be able to find it under the videos tab. All right, I'm going to start with some of our pre-submitted questions. Can you discuss the pros and cons of staying on an oral chemotherapy as maintenance for a set length of time, and does the benefit generally outweigh the chance of a secondary cancer?
The maintenance question has now been addressed in the best types of clinical trials. So, in informing what we should do, it's always good to have large clinical trials that compare one option to another and see if it's really better, as opposed to just a doctor feeling that something is better. And so for the maintenance question, there have been now several clinical trials performed here in the United States and also in Europe. Generally, as we discussed, maintenance treatment should be low intensity, and ideally it should be oral. You don't really want to be going back to the physician's office 6 times a week to get maintenance therapy. That's not going to help your quality of life. There are drugs that unfortunately have to be given either into the skin and cannot be given orally, like Velcade, and in some cases they're important. So as long as it's not too frequent, sometimes you have to do that. And the data show that for the vast majority of patients with myeloma, going on to maintenance, particularly with a drug called Revlimid, but in some cases also Velcade, can be beneficial. How is it beneficial? In almost all cases, it prolongs the duration of the remission over not getting maintenance. And at least in the United States study that was done, people actually live longer. So that's really a major benefit, because it's not just that your disease takes longer to come back. People who got the maintenance actually live significantly longer than people who didn't get the maintenance. So that to me is pretty clear cut. If you have survival benefit, then the question is, why would you not do it? The general answer is that for the vast majority of patients, maintenance therapy, often with an agent called Revlimid, but in some cases with other agents, is the appropriate strategy after you've had your initial therapy, ideally followed by stem cell transplant, or even if you've not had a stem cell transplant, then I think that's an appropriate strategy. The question asked whether, a limited period of time versus indefinitely, and I think the general consensus is indefinitely. The French did a parallel trial with the US where they gave it only for a short period of time. I think it was 1 or 2 years, versus the US trial gave it indefinitely until the disease came back. And the US trial had survival benefit, whilst the French trial did not have a survival benefit. So I think the general consensus is that you give it until either the disease recurs, or if the patient has such side effects that it's making their quality of life bad, so you really have to stop it. But other than that, you should continue it indefinitely. And you brought up the question of second cancers. There's a small but statistically significant risk of second cancers that is predisposed to by the drug Revlimid. That risk is small. It's very important to understand that. It is statistical, meaning that you can, by taking hundreds and hundreds, sometimes thousands of patients, show that there is a slight increase, and it's statistically real. It's not something that is by chance. But compared to the risk of your myeloma coming back, that risk is tiny. So whilst I inform patients about that risk, I think most patients have to understand that their primary objective is to prevent the myeloma coming back. That's what's really going to threaten their life. That's what's going to affect their quality of life. Second cancers, you could be one of the unfortunate small minority that develop a second cancer, but more likely you're not going to be. And so that typically should not be a limiting factor, in my opinion. Okay, so that's that question.
All right, thank you. Is multiple myeloma hereditary? Does a family member having multiple myeloma put me at greater risk for another blood cancer?
The answer is that in the vast majority of cases, it is not hereditary. Maybe 3 cases out of every 1,000 cases of myeloma may have a hereditary link. If you have a first-degree relative with multiple myeloma, your risk of having myeloma in your lifetime goes up 3.5 times compared to somebody who doesn't have a relative with myeloma, but it is still a relatively small risk. So for the vast majority of cases, no, it is not hereditary. If you happen to be in a family, and this is rare, where several members have developed myeloma, then you may have a gene that predisposes to it, and that's maybe worth investigating. But for most people, really, you don't need to worry that your family members are also going to get it.
Okay, good to know. Has there been any research as to why multiple myeloma is more prevalent among African Americans?
There's ongoing research, and I think it has to do obviously with genetic so-called polymorphisms, where certain groups, ethnicities have more frequency of certain types of certain genes, etc. And it's a complex process where the interaction of those genes with the patient tends to predispose to myeloma. So the short answer is no, we don't have a clear understanding of why African Americans are more predisposed to it, whether it is all genetic, whether there are differences in lifestyle, etc., that may contribute to it. But at this point, we know that African Americans are more susceptible. But it's not a sky-high increase in incidence. So, they're more at risk, but it's not like they're 10 times more likely. So we have to keep that in proportion. But no, the answer is we don't know the exact details.
All right, thank you. Are there tests that can be done to monitor for multiple myeloma before symptoms appear?
So there are, I think increasingly people have annual physicals, and part of that physical will be a chemistry panel. And a number of myeloma patients are diagnosed where their blood total protein is seen as being somewhat high, and then that leads to further investigations. Similarly, some people might have slight abnormality in the kidney function that leads to further investigation. So certainly, increasing number of myelomas are now being diagnosed without symptoms, where some abnormalities found on a routine physical exam. So that's one category. Then there's the category where somebody has found you to have MGUS or so-called smoldering myeloma, and the question is, how do you monitor that? And in those cases, you need some very specific tests. You certainly need the protein test we talked about, the SPEP, the immunofixation, the light chain test, and you probably need periodic bone marrow biopsies to see how the myeloma is doing. So it's different, depending on where you are. If you already have a diagnosis of a plasma cell condition like MGUS, you need different testing from somebody who's completely normal and just goes for an annual physical, where those tests are not appropriate.
All right, thank you. And are there common side effects of CAR T therapy, generally permanent, or should you expect some to subside over time?
So the side effects of CAR T-cell therapy are mostly temporary. They can be serious, and particularly if they're not treated quickly, they can sometimes be life-threatening. But they are, in almost every case, temporary in the sense that something called CRS, or cytokine release syndrome, which can cause fevers, low blood pressure, sometimes shortness of breath, and other organ dysfunction, typically happens early following the CAR T-cell therapy, and typically responds well to a drug called tocilizumab and 1 or 2 other therapies, and typically goes away once you treat it. Rarely it occurs later, but typically occurs very early. And once you get past that early phase, typically it's no longer a problem. Of course, if you don't treat it quickly enough, some of the organ damage that results can sometimes be long-lasting. But the whole idea is, in a specialized center, everyone's very trained as to how to look for it and treat it quickly, and it goes away. The neurotoxicity that occurs following CAR T-cell therapy, again, occurs in a proportion, not every patient, typically occurs at a specific time point after the infusion, typically responds well to treatment and goes away. So the vast majority of people, even though they may have some symptoms when they develop it, it disappears and they return back to normal. Again, if it's not treated appropriately or quickly enough, sometimes the damage can be longer lasting, and therefore it has to be given in a specialized center. There are some rarer side effects. There's a proportion of patients, a small proportion of patients, that tend to have low blood counts that can last sometimes for months after CAR T-cell therapy. In this respect, I think it's always good, to have prior stem cell collections. If you've undergone a stem cell collection, either for a transplant or collection without a transplant, and have those cells stored, then those stem cells can be used to treat those kind of low counts and resolve that problem. So this is another thing that we increasingly do in myeloma patients. We collect stem cells and have some available even beyond them getting a stem cell transplant, in case they need CAR T-cell therapy, and they have, in a minority of cases, low blood counts after that therapy, which can be treated that way.
All right, we have 5 more questions with limited time, so I'll try to get to as many of these as possible. One on autologous transplant, how are the harvested cells being genetically corrected if they contain the mutation?
So I think what you're asking is, can myeloma cells be collected as part of the autologous collection? And the answer is yes, they can theoretically be collected. However, we always do a bone marrow test before we collect them to make sure the bone marrow is clear of myeloma. Secondly, when the cells are frozen and thawed, typically myeloma cells don't survive that freezing and thawing process very well, whereas normal cells survive it very, very well. In the past, people used to try and purge the collection by, treating it with chemo and other things to try and get rid of any possible myeloma cells that are collected. It was shown that that really doesn't help, may in fact make things worse. So the answer is that we collect cells, and in most cases, collection of myeloma cells in that collection is really not a significant issue.
Thank you. Okay, can one reduce their cancer markers with a treatment to the point of SM or MGUS, not complete remission, and live comfortably in this stage?
Well, you never go to SM or MGUS once you have fully blown myeloma. That reverse flow doesn't happen.
Okay.
Well, I think what you're talking about is, what is the best response to myeloma treatment? And the best response in the past used to be complete response, which is where you can no longer see the myeloma protein, the bone marrow looks normal, the patient returns to normal in every other way. increasingly in the modern era, we look for even better responses. There's something called a stringent complete response, which is considered even better than a complete response, where certain other abnormalities return to normal. And now increasingly people are looking for what's called MRD, or minimum residual disease, whereby using some very sensitive tests like flow testing and certain genetic testing, you can detect even 1 in a million myeloma cells in the bone marrow, and can see that even at that level, you can't see myeloma cells. And those people that get to that very low level do much better, it seems, than people who get to not quite that level. So I think that's what you mean. You certainly cannot be called MGUS once you've already developed full-blown myeloma.
Okay, it is past 11. I want to be mindful of your time, Dr. Bashey.
I'm good if you want to ask a couple more questions. If I'm good if you have 2 more.
Thank you. Thank you so much. What is the difference between relapsed and refractory?
Relapse means that your disease was treated, it went away, and has now come back. Refractory means your disease is not responding to the last treatment. That could be initially, it's rarely patients with myeloma get their initial treatment, and for some reason, the disease doesn't shrink. That's very uncommon. Or it can be your disease has come back, relapse, and now has received some treatment and is no longer responding to treatment. That's called refractory relapse. So refractory means it's not responding to the last treatment.
Okay, is elevated ammonia levels characteristic of multiple myeloma?
No, elevated ammonia levels are a characteristic of liver disease and typically not a feature of myeloma.
I have smoldering myeloma in middle stage. For multiple myeloma, would a person who does not accept blood transfusions qualify for stem cells bone marrow transplant?
There are centers that specialize in so-called bloodless transplant. Our center tends not to do that, but there are centers, around the country that specialize in that. So if there are people, usually the Jehovah's Witnesses or some other religious belief that means that they cannot receive blood transfusions, they can go to those centers. You are inevitably increasing your risk of complications and death by refusing to receive transfusions during a stem cell transplant. Now, can you get away with it? Yes, you can. But the normal risk of death or serious complications is very low following a stem cell transplant. Typically at our center, less than 1% of patients will have a fatal outcome. But that risk, is going to go up if you say, I'm not going to have transfusions at all, because you can become quite anemic. Let's say you have a bleed or something, then you can't be transfused. So there are centers, as I say, that trying to provide this service. Our approach tends to be that we focus not on that particular entity.
All right, and one more question regarding the COVID vaccine. I'm 2 months away from ASTC. Is there any reason to get the vaccine prior, or will it be rendered ineffective by a transplant?
So when you get high-dose chemotherapy with stem cell transplant, so that's what you call ASTC, then typically your immune system is suppressed for several months following the procedure. Secondly, any vaccinations you've had before may no longer be as effective after the procedure. So in fact, our patients undergo a whole series of revaccinations, not just for COVID, but for things like, mumps, diphtheria, tetanus, all that kind of stuff. They get revaccinated starting at about 3 months following the stem cell, all the way through to about 2 years out. They get repeat vaccinations. Generally speaking, if you're about to have a stem cell treatment, then it's probably best to wait to have your COVID vaccine until after the stem cell. And the current recommendation is you get the COVID vaccine at 3 months following the stem cell. So, could you do any harm by getting the vaccine up front before the stem cell? No, but it's probably likely that the level of protection will not be great once you've had your stem cell. So you'll have to be revaccinated anyway at that point.
All right. Thank you so much for taking the extra time to answer those questions. I really appreciate that. That last question leads to a perfect segue into our program tomorrow that we're having on the COVID-19 vaccine that will be led by Dr. Ronald Tribble, who is an infectious disease specialist. So if you're interested in that program, that'll be tomorrow at noon, and you can sign up for that on our website, cscatlanta.org. Thank you again so much, Dr. Bashey. Do you have any closing statements that you'd like to make?
No, I think the important things that I would say would be that, remember, myeloma, even though it is a serious condition, we have made tremendous strides in terms of developing new treatments, and the survival is improving with each passing year. We have new treatment options each passing year. So really, it's an optimistic time, even if you have this serious condition, that you'll be able to live a normal life and live a prolonged life with this condition. So I think it's every reason to be hopeful.
Very good. Thank you. All right. Just a reminder to everyone, we did record today's program and it will be available on our website, cscatlanta.org, under videos. And thank you again so much. Everybody have a wonderful afternoon.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.